and thank you for being here. Today we are going to briefly discuss about the diagnostic and therapeutic implications and advantages of upper GI endoscopy in gastroenterology. How it is important to diagnose, how it is important to have the therapeutic implication while doing the procedures, including all upper and GI endoscopies. Since the introduction of GI endoscopy, the world has revolutionized the treatment strategies in the field of gastroenterology. Nowadays, the people are doing some marvelous and extraordinary work while doing the endoscopies. But in our part of the world, we all know we are very back almost 2 decades when compared to those people who are working on this field. So, to our extent, we are trying our level best to do at least some diagnostic and therapeutic procedures here in Gilgit, Baltistan. Since I have came, we have done a lot of work, and previously our seniors, Dr. Mehta Saab and Dr. Mubarak Shah Saab, have done wonderful work here in field of endoscopy, doing the all therapeutic and diagnostic endoscopies in their capacities. So nowadays, a lot of new modalities, lot of new interventions have almost changed the dynamics of these upper and lower GI endoscopies, and have brought very ease to the care of the patients. So this is a tremendous and very outstanding work people are doing. We have gone through, we have seen in different conferences, at least few work is being also done in our part of the world, especially in subcontinent like Pakistan and India. Today we have also a pictorial view of our patients, which we have done here in Gilgit, Baltistan for last couple of years. Though there was a lot of work and a lot of pictorial and videos we have, but definitely in one presentation it was not easy to cover. So just few glimpses I have collected here to show you what we have done here in terms of diagnosis and therapeutic purposes. So a brief view and introduction about endoscopy, its uses, its therapeutic and its diagnostic approach. We have made this presentation with along with pictorial view. So for the presentation, I would like to invite Dr. Tayyab, who had worked hard to make this presentation. He will give this presentation, and I will be here to tell what was the pictorial view to support him. I would like to invite Dr. Tayyab to come and proceed.
Good morning. I am Dr. Tayyab, resident medicine, and today I am going to present the diagnostic and therapeutic implication of GI endoscopy. First of all, I will give a short introduction about endoscopy. So, what is endoscopy? Gastrointestinal endoscopy involves use of endoscope, that is thin flexible tube fitted with a camera head and light guides. The gastrointestinal endoscopy is designed with patient comfort in mind, that this device moves smoothly in GI tract to provide clear picture inside of esophagus, stomach, duodenum and colon. Earliest description of endoscopy, what is history of endoscopy, and primitive forms of endoscopy have existed for hundreds of years, but it was not until the early 19th century that Dr. Philip Bosini invented an endoscope that would form the basis of modern endoscopy. So this was the first earliest invention of endoscopy, and this was the instrument that was used before as an endoscopy. Types of endoscopy, there are different types. First is esophageogastroduodenoscopy, that is used to examine esophagus, stomach and duodenum. And next is enteroscopy, that is used to examine small intestine. Colonoscopy, sigmoidoscopy to examine large intestine and colon. Rectoscopy to examine rectum. And capsule endoscopy, invented in 1990, involves wireless camera that travels through digestive tract, taking thousands of pictures. Endoscopy procedure depends to some extent on the reason for the endoscopy. There are 3 main reasons to carry out endoscopy. First one is investigation. Endoscopy can be used to investigate and to search the cause of any disease. Next is confirmation of diagnosis. Endoscope can carry out a biopsy to confirm diagnosis of cancers and other diseases. And third is treatment. Endoscope can treat an illness directly, such as can use to cauterize a bleeding vessel or removal of a polyp. So endoscopy can be used for investigation, confirmation and treatment. So these are the purposes of endoscopy. So here we have the pictorial review of a patient whose endoscopies were done, and that was used as diagnostic and therapeutic purposes. The first one is endoscopic picture of a distal esophageal tumor. Dr. Shan will explain some of the.
Yes, it's the endoscopic picture of a young guy who presented with the massive upper GI bleed, and patient had no previous comorbids, non-smoker and no other addictions. But the patient's history revealed that he took some Hakimi medications for a month given by her mother for his health. So after taking that, the patient landed with upper GI bleed, though few other pictures were very clear. Basically, it's a duodenal bulb, large duodenal bulb ulcer. That at the time of endoscopy, the ulcer was not bleeding and there was not active oozing. So we treated symptomatically with blood transfusions and high dose PPIs. Later patient got better and we discharged him on oral medication. So this was a large ulcer, almost 1.5 into 5 centimeter size ulcer, induced by most probably some Hakimi medications which he took for almost a month. So that's the guy was a young guy and his hemoglobin level dropped to 7.4 gram.
Next one is endoscopic picture of duodenal bulb ulcer of a young patient with history of Hakimi medication.
It was a young patient presented with the same issue and same upper GI bleed. Again, he was having the ulcer. It's not very much clear. So this is basically the ulcer which he presented, and same medication was given to the patient.
Would it not be better to give injections with chemotherapy?
Actually, he was not. He was not bleeding, and ulcer was almost on healing phase. So that's why we didn't intervene. Majority of these ulcers, usually the benign ulcers who once bleed, they will respond to conventional high dose PPIs.
And endoscopy, there is potential for rebleed. Already bled and hemoglobin dropped to 7.
Actually, we follow the forest classifications while treating the ulcers, class 1, 2, 3 and 4. If the ulcer is not bleeding and it's benign, clean based ulcers with flat spot, we usually treat symptomatically. If it's oozing, if it's actually bleeding, then we do some therapeutic interventions like we apply hemoclip, we do sclerotherapy and other interventions.
What about biopsy?
Usually we do the biopsy of the gastric ulcers and comparing the age of the patient and comorbids. If the patient is older, having the index bleed and if associated weight loss, we usually do the biopsy. But recommendation is to do the biopsy of every gastric ulcer. But sometimes if we have clear indication and clear cause like NSAID induced or a patient having the history of ischemic heart disease and he has taken antiplatelets and he has the bleed, we usually avoid to take the biopsies because we have clear reason and clear picture of the ulcers. But those ulcers who are malignant, who looking nasty, and the patient is really weight loss and patient is aged, then the recommendation is to take the biopsy from the ulcer edges. So it depends and varies to individual patient to which whom to take the biopsies and not to spare. Sometimes we try to spare the patient if we have the clear cause of upper GI bleed and clear cause of the ulcer. So that's why it depends on the individual patient.
Next one is endoscopic picture of a gastric cancer of 65 years of age.
So this is all about the cancer and extended up to the pylorus. So this patient also presented with postprandial fullness, vomiting and weight loss and anorexia. So this patient's biopsy report later on turned to be poorly differentiated adenocarcinoma.
Next is endoscopic picture of a colonic polyps of a female patient with history of PR bleed.
So this patient was a young lady presented with melena, hematochezia. So this was the picture, though other pictures showed very well polyposis all along the colon. So we took the biopsies of the polyps and removed which was possible up to the 5 or 6 polyps, So this was a young lady who presented with melena and PR bleed.
Pre-pyloric large ulcer.
So this is an ulcer, pre-pyloric ulcer. So this looks, in this case you can see this looks a bit nasty ulcer with surrounding edematous mucosa. So we took the biopsies, and the patient, this patient also presented with melena, plus he had weight loss and anorexia. So that's why we took the biopsies of this ulcer. But fortunately this was not malignant, it was a benign ulcer. Later on we confirmed on biopsy.
Gastric growth.
So this was also a gastric growth. It was also a gastric CA actually. You can see it's large tumor partially obliterating the pylorus. So biopsies later confirmed it was also a adeno-CA.
ERCP extraction of a large
this
stone
was
from
actually, we know ERCP is not being done here, but this was a patient presented with obstructive jaundice. I referred this patient to the Don countries. So Dr. Adnan there did his ERCP, and later on he shared the pictures with me. So it was a large, huge stone, you can appreciate, which was retracted and with ERCP. So this was quite a large stone, that's why I showed this picture.
Hemorrhagic gastritis.
So this patient had actually long history of NSAIDs very much frequently. So a few other pictures was very clear. So he had presented with some severe epigastric pain and history of melena off and on. And his endoscopy showed it was almost the pre-pyloric and whole antrum was hemorrhagic and with erythematous mucosa. So we took the biopsies as well. Later on the biopsies turned out to be H. pylori induced gastritis, but that was hemorrhagic gastritis, pain gastritis with pre-pyloric severe erythema. You can appreciate.
Esophageal varices.
So we have very less number of patients with decompensated chronic liver disease who report to us, but nowadays the number has increased. The patients with decompensated chronic liver disease secondary to viral infections and some other causes, and we had a number of patients with non-cirrhotic portal hypertension and some other unknown etiologies. So this was the patient, our follow-up patient, who we previously done his AVBL. So again he presented with these esophageal varices. The pictures are not very much clear, but you can appreciate the esophageal varices, the multiple columns of esophageal varices. The patient presented with upper GI bleed. So second time we did his esophageal varices bending ligation endoscopically.
Fundal varices.
Yeah, this one is the picture of the patient. He is also decompensated chronic liver disease patient second due to hepatitis C virus. So you can see here are the medium-sized fundal varices. Previously, his EVBL has been done, and one time his sclerotherapy of the fundal varices has also been done in Islamabad. But this time again he presented, but his cause of bleed was esophageal varices, but he had these fundal varices also. So we banded him, his EVBL was done, and for the fundal varices we will refer the patient back to the primary gastroenterologist.
Duodenal ulcer with visible vessel.
This you can see is also an duodenal bulb ulcer with visible vessel. The patient again presented with massive upper GI bleed and melena. So we did his upper GI endoscopy, which showed this. We did the injection sclerotherapy of this patient. At that time when he presented, he was having actively using. So we did the sclerotherapy with adrenaline. So patient later on became stable hemodynamically. The second look endoscopy was also done, which showed almost healed ulcer. So we put the patient on high dose PPIs, and he's on follow-up now.
Colonic ulcers in a patient with ulcerative colitis.
This was the patient. This was a patient, 45-year male patient from the Amar, who presented with PR bleed and melena. So this was the picture of a whole colon was almost ulcerative up to this splenic flexure. So initially we thought having some infective cause and ulcerative colitis, or to be very rare is the Crohn, but later on his biopsy was done, which turned out to be unfortunately it was ulcerative colitis. So the patient is on treatment now.
Distal esophageal tumor.
This is a distal esophageal tumor. This is some food you can see is impacted because of this narrowing. So esophageal tumors being most common in our part, so we usually confront 2 or 3 patients almost in a month or sometimes in a week. So this is the esophageal tumor, distal esophageal tumor.
Gastric carcinoma.
So gastric CI, we have a lot patient, more patients here in GB. We are well known about the gastric CI. It's very common. So just to see that the for diagnostic purposes and for therapeutic, we usually do the endoscopies of the patients having the symptoms. So gastric CI is very much common and very much frequent nowadays. So this is the cancer.
Worm infestation.
Worm infestation is again very common in our parts, leading to the biliary ascaria and pancreatitis. So lot of patients who came to us, particularly female patients who present with lot of worms obstructing the whole lumen and having the biliary ascaria. So this is the worm infestation. It's very common again.
Colonic mass.
That was, you can appreciate, it is a whole mass involving the colon. It was a lady, almost 55 years old lady with weight loss, anorexia and chronic constipation. So we did her colonoscopy, and this mass later on biopsy turned out to be a malignant adenocarcinoma.
Impacted bone piece from esophagus removal.
So foreign bodies are always, and we usually deal, and particularly in the times of winter times when people usually had the dry meat, so these bone pieces and meats are impacted, particularly those patients who had already some underlying strictures and some underlying narrowing. Usually they had impacted bone pieces, impacted meat boluses. So we did a lot of endoscopies and detected by these forceps. Sometimes forceps, for lack of instruments, we usually take the help of the biopsy forceps, upper or lower biopsy forceps, grabbing the piece or bolus. If it's not sometimes possible, then we usually, the meat boluses, we usually push down to the stomach for the ease of the patients. And if the underlying, you can see, usually patients have underlying strictures, sometimes ulcerations and narrowings. So we take the biopsies to rule out underlying is any esophageal causes, any eosinophilic esophagitis. Sometimes some infections can lead to these strictures and narrowing of the esophageal lumen.
Esophageal versus band ligation.
So this was the EVBL we have done of a patient with upper GI bleed. So you can see these are the varices, and this is the drum of the varices, and these are the bands we have applied to the esophageal varices. The patient presented with upper GI bleed, and his banding was done. Usually we had the set of 4 or 5 or 6 bands we apply, depends on the number of varices. Usually we had the 10 shooters as well. If the varices are more, and if not covered with these 6 bands, we usually apply up to the 10 bands as well.
Colonic polyposis.
So this was a young girl, basically 17 years old. She was presented with the upper GI bleed. So this is the picture of his colon, multiple polyposis of the colon. We took the biopsies, and later we turned out to be Peutz-Jeghers syndrome. So the girl has freckles and typical presentation. She was 17 years old girl.
Esophageal candidiasis.
So this was a young guy who presented to us with dysphagia. Previously he was seen and treated in Karachi AKU. Later on he was referred here, and he presented with absolute dysphagia, and sometimes he was only taking liquids. So this picture showed the mesoesophageal candidiasis. I took the biopsies for the purpose of diagnosis, but unfortunately later on it turned out to be an HIV infection. So this was a young guy. Now he is under treatment of the infectious control specialist.
Benign gastric polyp.
So that is the benign gastric polyp. It was resected and removed, and biopsy turned out to be a benign gastric polyp.
Duodenal ulcers.
No, sorry, actually it was a duodenal lesion.
Oh.
So we did upper GI endoscopy. The patient presented with massive upper GI bleed. It was a 40 years old male patient having no previous history of any NSAIDs, smoker or any other comorbids. So this was a lesion.
Biliary ascaria.
So this was a large ascaria. So we almost tired while extracting these worms, a lot of worms, almost 10 to 15 centimeter size worms. Large worms usually impact in the CBD and with lot of worm infestation. So actually our people are unaware about this deworm scenario. So now we are trying to educate the people about the deworming plus some hygiene, and we are trying to aware the patient about taking the anti-helminthic drugs plus about the hygiene. So that was the only reason that people usually present, particularly our female patients usually present with iron deficiency, anemia, with these biliary ascariasis, pancreatitis and other complications.
Colonic mass.
This was a young guy, almost 25 years old, presented with constipation and lower abdominal pain and bleeding PR. So I did his sigmoidous colonoscopy, and there was a large polyp with the thick pedicle. So I didn't reject this because of fear of the bleeding. So I referred the patient to the Don. There they rejected, and unfortunately this turned out to be a malignant polyp. So the patient is under chemotherapy now, and he is doing well now. He is a young guy, almost 25 years old.
Liver biopsy.
So this is a liver biopsy pieces we done in a patient who presented with non-alcoholic steatohepatitis for the confirmation of the diagnosis. So the diagnosis was again the NASH. He was having the fibrosis F3 on the fibroscan. So that is the liver pieces you can appreciate.
Duodenal bulb ulcer.
Again, this is you can appreciate the same ulcer with the patient who presented with upper GI bleed. Almost 3 or 4 patients previously presented having the same location and same size of ulcer in the duodenum. So that was the AASLD liver conference last November. I attended in America. That's the most biggest and largest forum of our liver disease. The organization that formulates the guidelines for the rest of the world. That is the American Association for the Study of the Liver Disease, and that was held in last November in Boston, USA. There is some glimpses. We used to attend the workshops in twin cities of Middle East in Islamabad when we were in training. Professor Umar Sahib is here. So this man is doing very hard work to arrange these conferences, hand-on workshops, and a lot of work this man is doing.
So we have some recent advances in GI diagnostic and therapeutic endoscopies. That are some recent advances. The first one is endotherapy of GERD. So how we can use endoscopy or endoscopic instruments for the therapy of treatment of GERD. So first one is
So all these are the advances. The people are doing these techniques regularly, routinely in advanced countries. So we don't have these much facilities here in Pakistan, but fortunately few of them are being done here in good centers. But most of them, these procedures are being done regularly and routinely in some advanced centers and in advanced countries.
Next one is endoscopic suturing device.
Yes, so basically this is an ESD, endoscopic suturing techniques, through which we can treat like ESD. We have EMR and POEM nowadays are being regularly done in some good centers.
Full thickness spicullator. This also used for treatment as endoscopic treatment for GERD.
So these are the practicing techniques in developed countries people are doing nowadays.
Strata technique.
So strata technique is basically a technique for that inclines the radio frequency waves to the gastroesophageal junction. So this is the device. Actually it's a balloon and attached with the electrodes, through which we usually supply radio frequency energy in a series of small thermal injuries and to the lower esophageal sphincter to reduce the transient LES relaxation and perhaps alter the dynamics by which reflex takes place. So this is basically a strata technique through which we can control the reflex esophagitis. With the application of this technique, almost the use of PPIs has reduced from 80% to almost 23%, and also the GERD and heartburn score is almost decreased to 35% in 1 year. So this is the pictures pre and post strata techniques.
Indirects.
That is basically injection of ethylene vinyl alcohol polymer into muscular layer of LES to increase its bulk. So all these techniques are basically for the therapeutic purposes. The procedure increases the LES pressure and led to a sustained reduction in heartburn score. So this is also a more advanced than strata technique. These are the pictures we have only seen in the pictures. So the capsule endoscopy, we are all well aware this endoscopy, capsule endoscopy, has almost revolutionized the use of this endoscopic techniques, and it's very easy, and but though it's very expensive, we are not doing here, but in good centers people are routinely doing, because it's a disposable capsule. 50,000 to 60,000 images, depends on the technique. 5 hours of recording stored, 9 GB hard device transmitted to a recorder worn by patient, analyzed in 20-minute video clip, ability to localize places of lesions during analysis.
Next is magnetic colonoscope imaging.
So capsule endoscopy has lot of therapeutic and diagnostic implications. We all know, particularly the lesions of small intestine and those lesions who are not being diagnosed by a conventional endoscope. So this capsule endoscopy has done, particularly the patients who are unable to tolerate the endoscopy. Capsule endoscopy is a good diagnostic and modern technique through which we can pick and we can diagnose, and we can also go for therapeutic strategies accordingly.
Yes, next. CT colonography, virtual colonoscopy.
And MR colonography are also virtual colonoscopy through which we can diagnose the large lesions of the, because it's 10-minute procedure, use CT scan, there is no sedation. Polyps and large cancers we can detect, sensitivity is 75% and specificity is almost 90%.
So here we have here some video clips of some procedures done.
So this video is this is actually PEC tube insertion we did here in Gilgit last 1 month ago. This is a patient who was having the buccal mucosa, CA buccal mucosa on right side. He was unable to take food, so we put the PEC tube in this patient, and alhamdulillah the patient is now doing well, and his the PEC tube is almost no, it's almost 2 months almost since we put the PEC tube.
Same patient and same procedure, PEC tube, and endoscopic view
this
of
is
PEC
tube. This is the PEC tube.
This is
which you put after the PEC tube. We inserted the PEC tube. दोबारा से दिखाएं.
Yes sir.
वो उसको दिखाएं, वो जो ये. So this is the stomach, and this is the tube inside. So we can administer food and all that through this tube.
Next video is endoscopic view of bone
last
manifestation.
videos, and hopefully all those who have taken breakfast and those who have not taken breakfast, they will delay the breakfast for 1 year after seeing this video. These are the worms. You can see a lot of cluster of worms, an army of worms. You can see here is a lot of worms, almost 6-7 worms. This is the duodenum, and the patient was having the biliary ascaria. So along with the biliary ascaria, he was having, this was a female patient, having multiple worms in the duodenum. The mobile worms. So usually if the worms were 5 or 10 worms, we usually unable to pick one by one. So the one who is stuck in the CBD, we usually detect the worm and rest of the worms we deworm the patient. So they usually die after when we administer the anti-helminthic drugs. So this was all about brief presentation about the diagnostic and some therapeutic, brief therapeutic indications of the endoscopy. So though there is a lot of work being done nowadays, and endoscopically people are doing surgeries like appendectomies, like cholecystectomies, and all the bariatric surgeries are being done. Plus they are doing POEM, they are doing ESD, SM, SRDs, all of they are doing in rest of the world. But we are still doing the diagnostic plus some available therapeutic interventions here. And in our country, Alhamdulillah, a lot of expert people are here, particularly in big cities. They are doing very wonderful work in the field of endoscopy. They are treating the GERD, they are doing the suturings, they are doing the POEM, they are doing the ESD. Some big procedures they are performing in Pakistan, like in Islamabad, Karachi, and Lahore. So occasionally we go and attend these workshops, and we see they are doing very wonderful work. But here, unfortunately, you all well know, we don't have even a gastroscope in any government setup hospital in 2024. This is very pity and unfortunate. The one endoscope I brought with from donation of a patient, still that is in the PSQ, but out of order. We had an endoscope here that was almost an absolute model given by the contractor. That was just a gastroscope. But currently we don't have any gastroscope, any colonoscope in any hospital of in any government hospital of the GB. So these are procedures we doing in our private setups, private hospitals, because if we are not doing there, so any emergencies, the patient would be referred to down countries. So misfortunately we are doing in our private setups, but on the part of government, they are not taking it seriously. They think endoscopy is a bit of rubbish thing, doesn't need in government hospitals. So a lot of poor people who came, majority of them are not affording to go to down countries and to doing endoscopies in private setups. So that's why we usually avoid to send them back, because they have restricted financial problems. That's why. So there is need to make sure of the availability of this endoscopy system, at least in our setup, where we have started the residency programs, Alhamdulillah. So we have a lot of residents, but the course are unable to see the endoscopy practically. So I request the sir to put on